Good afternoon, everybody. I think we'll get started. I just went out there and looked. I don't think anybody's coming right now. I'm Robert Karch. It's very nice to be here. I'm the Deputy Secretary for Children's Medical Services. It's great to be here. This is my first Family Cafe. I've already had the great opportunity of meeting Marisol Rose and her team of family resource specialists with Early Steps program. And I see what this conference is about. I've heard a lot about Family Cafe over the last year. I'm new to the Department of Health. I joined about a year ago. I'm from Orlando. Before joining the Department of Health, I was a pediatrician at Nemours Children's Hospital here in Orlando and an associate professor of pediatrics at the University of Central Florida College of Medicine. Just a little bit briefly about myself. I'm from Pennsylvania. I grew up in a little town called Kutztown, Pennsylvania, about an hour north of Philadelphia. It's kind of Amish Mennonite country, if you've seen pictures or been. Went to school at the University of Delaware for undergrad, and then up to Columbia University for my Master's of Public Health, then down to Georgetown for my medical school. Then really had an interest in coming to Florida and trained to do my pediatric residency at Miami Children's Hospital, what was then Miami Children's Hospital. It's now Nicklaus Children's Hospital, and spent 4 years in Miami. When I was at Georgetown in med school, I enrolled in a program called the National Health Service Corps, and that's a loan repayment program. So in return for some loan forgiveness, I would agree to go work in an underserved area somewhere in the United States. And so after interviewing all around Alaska and different areas, I settled on northern Arizona, a place called Canyonlands Community Healthcare Center, which is right on the Arizona-Utah border in a little town called Page. And this is right on the Navajo Reservation. So 2 of our clinics were on the Navajo Reservation, and then we had another clinic in the Kaibab Paiute tribe reservation. So it was a really remarkable experience. It was there that I became interested. I'd always been interested in nutrition. There's not a lot of outlet for nutrition in medical school. You get a very brief exposure during biochemistry, but nutrition was always my interest. And so because most of my patients had some nutritional problem, whether it was under or over nutrition, dental caries, dental hygiene was really quite an issue on the Navajo Reservation, I decided to go back and do a fellowship in pediatric nutrition at the Children's Hospital of Philadelphia, and also did a fellowship called the Robert Wood Johnson Clinical Scholars Program, which is a health policy training fellowship at the University of Pennsylvania. I had been at the University of Delaware. I became familiar then with the DuPonts and the Alfred I. DuPont Hospital for Children, and then I heard that Nemours was starting a hospital in Orlando in 2010, and decided to come back to Florida. I met my wife when we lived in Miami, and she had always wanted to come back to Florida. So coming back to Orlando was a plus. She had come to the Navajo Reservation with me and then to Philadelphia, and so she was eager to get back to Florida. And we came from Philly to Orlando in 2011. And I was just mentioning to Sue, we came from Philadelphia to Melbourne, and really helped get the inpatient pediatric unit up and running for Nemours Children's Hospital a year and a half before the hospital opened its doors in October of 2012. And then once we opened, everybody moved in to Orlando. And I'd been with Nemours Foundation from 2011 until just last year, 2020. I teach nutrition at the University of Central Florida College of Medicine, developed the nutrition curriculum for the medical students, led the pediatric clerkship for several years in general pediatrics, and then decided last year to come to the Department of Health, and I started in March of 2020. So I haven't been here this long. I missed the conference. I think it was virtual last year. This is my first Family Cafe, and I've just been thrilled to be part of Children's Medical Services and the Department of Health for the last year, getting to know the spectacular programs and services for children and youth with special health care needs has really been a privilege, and I'm still learning. So conferences like this, experiences like I had this afternoon with Marisol and her team really are informative, and that family resource specialist program, to me, after learning more and more about it, it's really so critical, programs like that, to get the family perspective, families of children and youth with special health care needs who've been through the system, who understand the ups and the downs, the hurdles. I need to hear those stories and those barriers so that we can improve our program, because that is what Early Steps and other programs like it is all about. It's for the children, it's for families with special health care needs, and we want to make it better and not just a bureaucracy, which it can be. It's massive. So I thought today what I wanted to do was actually give an overview of the Florida Department of Health. Before joining a year ago, I had no idea even the extent of the Florida Department of Health. It's a massive organization in 67 counties. We live in the third most populous state in the country. And the Florida Department of Health we have 14,000 plus employees in all 67 counties. And I thought it would be useful for everybody, because it's been useful for me over the last year to really learn about the different divisions and bureaus and sections of the Florida Department of Health. And then, of course, we'll talk about children's medical services and Early Steps in particular. And we'll have plenty of time for questions and answers. And we do have Marisol and her team of FRS is here. And if we don't know answers to your questions, we can certainly get your contact information and get back to you with answers. So with that, the Department of Health is established in statute, and our mission is to protect, promote, and improve the health of all Floridians through integrated state, county, and community programs. And that integrated is really the key word, and the one that I've found is the bugger right there. So integrated between the state health office and the local community. And that's where we really need to focus on that integration. I think the division, the county health department breakdown is beautiful and needs to be utilized more, because that's really how we get the policy from the state office integrated, and then we need to see that feedback from the local level back up to the state level, so that we have a continuous cycle of improvement. And we provide public health services to protect people from disease and injury, and encourage behaviors that promote health and prevent disease. These are our major responsibilities. We conduct surveillance of disease, accumulating health statistics necessary to establish trends, implementing interventions based on that data to help prevent spread of disease. These vital statistics are so important to inform our health policy, maintaining preparedness procedures for public health emergencies, such as we've experienced in the last year, environmental regulation on issues that impact health. The Piney Point issue, just in the last couple of months down in Manatee County, is a perfect example of how the Department of Health intervenes on environmental issues, harmful algal blooms, for instance. And then licensure and regulation of health practitioners to preserve health, safety, and welfare of the public. We have the administration at the state level, which is in Tallahassee. And I go to Tallahassee during the pandemic. I was there weekly. I have the advantage of being able to be in Orange County several days a week, and then I'm up in Tallahassee Mondays and Tuesdays. So I really, through my arrangement, have gotten to see the workings of the state office, but also the local offices, and for instance, the Orlando Center for Children, and see how things work at the county level. And then the 67 health departments that I mentioned before. There are 8 statutorily required divisions within the Department of Health, and here they are: the Division of Administration, Emergency Preparedness, Disease Control, Community Health Promotion, Public Health Statistics and Performance Management, Medical Quality Assurance, Disability Determination, and of course, Division of Children's Medical Services. So I'll just briefly describe each of these. Here's the organizational chart. Again, a massive organization, 14,000 plus people. You can see here the State Surgeon General, currently Dr. Scott Rivkees, Chief of Staff, Cassandra Paisley. Cassandra was the Director of Children's Medical Services, and she spoke here at Family Cafe 2 years ago representing the Department of Health. She's now the new Chief of Staff as of about 2 months ago. And then you have General Counsel, you have the Office of Inspector General, and then the State Surgeon General reports directly to the Governor. And then the blue boxes here are the Deputy Secretary. This is my box here, Deputy Secretary for Children's Medical Services, Deputy Secretary for Health, Deputy Secretary for County Health Systems, and Deputy Secretary for Operations. And then here you have the 8 divisions that I just reviewed here. Again, here's Children's Medical Services. And then in blue are the bureaus. So the Bureau of Early Steps and Newborn Screening and the Bureau of Child Protection and Special Technologies are the two bureaus. Now, we also have an office of CMS, the Office of the CMS Plan, the CMS Managed Care Plan, and the specialty programs, programs like Title V, like medical foster care, and so on. So that is CMS. Any questions on the organizational chart? I didn't know this, all of this when I joined even a year ago. Again, here's county health department. So your local, wherever you're from, your county health department is one of 67 county health departments here. Okay, medical quality assurance, this is your licensure, all of your licensure boards. There are 22 professional licensure boards, including the Board of Medicine, Board of Nursing, and so on. This is where everybody there falls. Okay, so emergency preparedness, again, the main task for emergency preparedness is to strengthen the health and medical response system throughout the state in the event of emergency, and we're an emergency-prone state. So you see here the Bureau of Public Health Pharmacy, Bureau of Preparedness, Bureau of Radiation Control, and the Emergency Medical Oversight. Bureau of Radiation Control, again, I mentioned Piney Point, the phosphate contamination just within the last 8 weeks or so. Bureau of Radiation Control really had a large part to do with testing the water from the Piney Point and the Bay, the Gulf of Mexico, sorry. Division of Community Health Promotion, again, the goal there is to help Floridians make healthy choices, to protect, promote, and improve their health. Here we have the Bureau of Child Care Food Programs, the Bureau of Chronic Disease Prevention, Bureau of Family Health Services. This is where Tobacco Free Florida sits. WIC program, Women, Infant, and Children, and Public Health Research Unit. In the Bureau of Family Health Services, this is where your section of violence and injury prevention. So all of our injury prevention efforts fall in sections. So beyond the, if you remember the blue bureaus, further division, which I didn't show, are all the different sections. So again, to emphasize the massive structure that is the Florida Department of Health. Division of Disease Control. This comprises the public health laboratories. We have 3 primary public health laboratories in Florida. The main public health laboratory is in Jacksonville, and that's the public health lab that oversees our newborn screening program. I'll talk more about it, but we screen for 57 metabolic, genetic, and other conditions in Florida. And this is the public health laboratory in Jacksonville that oversees those efforts. Bureau of Environmental Health, again, Piney Point, very much involved in environmental health. Communicable disease, so sexually transmitted diseases fall here. And then our immunization section falls within this division. So our vaccine for children program, for instance, falls within the Division of Disease Control and Health Protection. Here's medical quality assurance. I mentioned MQA before. This is the professional boards here, regulation, licensure, investigating complaints, inspecting facilities, prosecuting Practice Act violations, and so on. Public health statistics and performance management. For me, this is a critical piece of the Department of Health. Public health statistics collects vital statistics, our birth statistics, death statistics. It's responsible for establishing the state health improvement plan with our statewide stakeholders. So right now we're undergoing our next 5-year state health improvement plan development. It'll be released in January of 2022. We just had our first SHIP, State Health Improvement Plan, kickoff meeting about 6 weeks ago in Tallahassee. We're going to be going, the next meeting is in July here in Orlando, and we'll be working with our stakeholders throughout the state, our county health departments. The county health assessments feed up into that state health improvement plan and really shape it, so for the next 5 years. And you know, they're also involved in our quality improvement programs, so rapid cycle PDSAs, to improve, and they have all the expertise if we want to use a rapid cycle Plan, Do, Study, Act on a program to make it better. All the experts on quality management and performance management are housed in this division here. And then disability determination. This determines medical eligibility for individuals who apply for disability benefits. Really important. The Office of Minority Health and Health Equity. This is the office that's responsible for coordinating our efforts to design and develop programs that impact minority populations, such as the Closing the Gap program. Office of Medical Marijuana. This is the office that's responsible for implementing the department's rules for medical marijuana and overseeing the medical marijuana use registry. Here are our county health departments. These are the implementation arms of the Florida public health system. Again, we're in every one of the 67 counties in the state. And their major functions are to prevent, minimize, and contain adverse health effects from communicable disease, outbreaks, unsafe food and water, chronic disease, environmental hazards, injuries, and risky health behaviors. Each county health department has a different portfolio of services. Some actually see patients, some don't, and those that don't actually partner closely with a community health program in the area. And then the Division of Children's Medical Services. So our main function is to provide services to children and youth with special health care needs. We have two bureaus, as I mentioned before, Bureau of Early Steps and Newborn Screening, and the Bureau of Child Protection and Special Technologies. So our 22 child protection teams, okay, these are the teams that investigate allegations of child abuse after they come in through the Department of Children and Family Child Abuse Hotline. We have medical experts throughout the country that can actually determine medically whether or not child abuse occurred. We have our Bureau of Public Health Laboratories. I mentioned our state lab and the newborn screening program. Our 15 early steps offices, and we really should have the family resource specialist here. The 15 early steps offices and the FRSs there in early steps, and then 14 sexual abuse treatment offices throughout the state. We're established under statute. We're a discrete division within the Department of Health. And again, we include our statewide managed care program, which many of you probably know. We underwent a major transition in 2019 after an entire history of providing direct care services at our sites throughout the state. We transitioned, and now that is administered through our partner, WellCare. And so things are quite different in the last 2 years, I know, and we're in the process of really offloading all of those buildings, the 22 different buildings that we're down to 4 right now. 3 will be transitioned out in July, and then we're going to retain 1 building in Children's Medical Services. So massive transformation since February 1st of 2019, really since about the time of the last Family Cafe. And our goal is to provide essential preventive, evaluative, and early intervention services for at-risk children. And here's just a infographic. You can see all the different programs: newborn screening, early steps, newborn screening, follow-up newborn hearing screening, okay, early steps program, child protection team, poison information center network. So all 3 poison control centers in the state. We have 1 in Jacksonville, 1 in Tampa, and 1 in Miami, all associated with the major universities in those areas. And then our Poison Information Data Center is housed in the Jacksonville Poison Control Center. So this is really, how did that get here? Different political dealings throughout the decades. Poison control landed in CMS. It could easily be in injury prevention or in environmental services, environmental protection. It's with us, and so we administer it. And poisonings are an important cause of accidental, unintentional injury in children, and a cause of intentional injury in adolescents and seniors. And so really room for improvement right here, and we're focusing on that this coming year, bolstering our poison control centers. The sexual abuse treatment program I mentioned briefly. We've also conducted a statewide survey of our SATP program, deciding where we can expand, which areas of the state aren't covered with a sexual abuse treatment program, to provide services for those people who have been sexually abused. to return them to their pre-abuse level of functioning. The Child Abuse Death Review System, the CADER, this is a unit within child protection teams that really investigates and looks at the data around child fatalities in the state, works with the local and state CADR committees to analyze the data, and then generates a report to the governor each year on childhood fatalities. Also in statute is to use that data to develop innovative prevention strategies to prevent these preventable causes of death. And the top 3 causes of death, as reported for those kids who are reported through the Child Abuse Hotline, are sudden unexplained infant death due to sleep, so sleep-related infant deaths under 12 months of age, so your SIDS, okay, your sleep-related deaths, drowning, and inflicted trauma. And so this year, we are really making a concerted effort to attack the first 2, sleep-related infant deaths. We're partnering with an organization called Cribs for Kids out of Pittsburgh to get all the maternity hospitals in the top 8 counties for SUID counts, sudden unexplained infant deaths, all the maternity hospitals certified as Safe Sleep certified. That means that the nurses on the maternity wards, the parents who come through and delivering their babies are all instructed during their time in the maternity hospital on safe sleep practices, the do's and the don'ts. The curriculum for that is developed by the National Institute of Child Health Quality, NICHQ, which is one of our trusted partners. It's a high-quality program. There are different levels of certification, bronze, silver, and gold. And our aim is to get all maternity hospitals, and there are about 121, 122 hospitals in the state that deliver babies, all of them eventually, but we're starting with the top 8 counties to get those 63 hospitals in those top 8 counties Safe Sleep certified. And we think that'll have an impact on our infant death rate due to suffocation. Our drowning efforts, we're partnering with Florida Public Media. This is PBS and NPR, and we are airing, and soon to come, if you watch PBS Kids, Sesame Street, Daniel Tiger Neighborhood, I think, hopefully, if all goes well, you'll soon see lots of public service announcements on drowning and really promoting the layers of protection. So adequate parent supervision, adequate barriers around pools, high-quality swim classes, and knowing CPR. These are the 4 layers of protection. The PSAs that we're developing and using, which you'll see on PBS Kids and NPR, really focus on that 4 points messaging. Children who are on the autistic spectrum disorder are at an increased risk for drowning. The data supports that, and so we'll have special attention for autistic children and drowning prevention. So I'm really excited about those 2 things. We want to take the data and not just generate a report, and it's an excellent report, but going the step further and making sure that this never happens again. And then our State Systems Development Initiative is our epidemiologists and biostatisticians that help support us with data. Again, I think most of you know a little bit about our newborn screening program. There are 4 million babies born each year in the United States, about 221,000 babies born each year in Florida. We're a mega state. That's a lot of babies born each year, and every single one of them, unless the parents opt out, have a heel stick test, and their blood is sent to the state lab in Jacksonville to screen for these rare metabolic and genetic conditions, which, if caught early, can really be impactful in preserving and promoting health outcomes. So we screen for 57 conditions now. Since the last Family Cafe, we've added 3 more. I know that when Director Paisley spoke 2 years ago, the Department of Health was in the process of gearing up for Pompe disease, mucopolysaccharidosis 1, and spinal muscular atrophy. We've since implemented all 3 of those in 2020. Spinal muscular atrophy went live right around Memorial Day of last year, so we're just over a year in successful implementation of those 3. That's a lot in 1 year for our state lab. The functions are to follow up on all abnormal newborn screening specimens, providing quality assurance for abnormal cases, case management, technical assistance. So in normal times, we would send our teams to the hospitals to make sure that the blood specimens are collected appropriately, that the specimens are sent expeditiously to the state lab and don't sit in a hot mailbox somewhere in Florida for several days before getting to our state lab. And so we're really working on transit time and specimen quality, the unsatisfactory rate, bringing that down. Those are our quality metrics that we're focusing on this year. And then we have the GenSAC, the Genetics and Newborn Screening Advisory Council, which are experts and parent members as well, who advises our teams on genetic diseases. Newborn hearing screening. This is the Newborn Early Hearing Detection and Intervention Program. It's established by statute to screen, identify, and connect newborns who have differences in hearing, who are deaf, to adequate early intervention services. And so our EDDI goals across the nation are 1, 3, 6, screen by 1 month of age, diagnose with hearing loss by 3 months of age, and then refer into our Early Steps program by 6 months of age. And we're really working on each one of those components there. Newborn hearing programs, again, following up on all newborns that don't pass the initial hearing screen, contacting parents and providing education, communicating with healthcare providers like pediatricians and family doctors to ensure all hearing, and audiologists to ensure all hearing is reported, and then referral to our Early Steps program. And then there's the EDDI Advisory Committee, again, a committee of specialists, parents, advocates to inform our EDDI program. Early Steps, I think most of you know about our Early Steps program. The Early Steps is the Individual with Disabilities Education Act Part C program here in Florida. We call it Early Steps. Other states, early intervention. Early Steps is our Part C program here, and really focused on enhancing the development of infants and toddlers with disabilities or diagnosed with conditions which could lead to developmental delay. And one of those conditions that could lead to developmental delay is neonatal abstinence syndrome. So for babies born exposed to opioids, and we have a real opioid exposure issue, neonatal abstinence syndrome babies are at increased risk for developmental delay. And so all should be referred immediately, early on, while even still in the hospital, to our early intervention program. This is something that we've discovered isn't happening as much as it needs to. There are about 1,400 NAS diagnosed babies each year, and at the most recent year that we have data, only about 400 of the 1,400 were actually referred in. And so we have some work to do. And I think that with our newborn safe sleep program, we're going to be establishing those contacts in the maternity hospitals that will also help us with getting babies diagnosed with neonatal abstinence syndrome into Early Steps. We need help from Early Steps, though, and through ChildFind to work with local hospitals as well on the other side, on the other end, to get babies who are diagnosed with neonatal abstinence syndrome into the Early Steps program early, not at 2 years of age. We're also working on this from our child protection team. If a child is alleged to have child abuse, we're making sure that all kids who come in through the CPT program who have a diagnosis of neonatal abstinence syndrome get in, but that could be at 2.5 years of age. Early Steps only goes to 36 months. So it really needs to be from the diagnosis in the newborn nursery or the NICU. The state office in Tallahassee provides oversight for the following policies, procedures: quality assurance, technical assistance, fiscal management of our grants, dispute resolution. We have, as you know, 14 local Early Steps providers around the state. These are responsible for local program oversight and service delivery. We don't have the family resource specialist here, and for the next time we'll have this. No, family resource, oh, okay, they're there, service coordinators and family resource specialists, okay. Early intervention service providers, and then of course our FICIT program. So I'm gonna highlight it and actually build it out a little bit more. I mentioned the Office of Children's Medical Services, Managed Care Plan, and Specialty Programs. Again, providing services to children and youth with special health care needs through a variety of programs, including our CMS Managed Care Plan with WellCare, our Title V programming, medical foster care, the CMAT, Multidisciplinary Assessment Team, our RIPIC, Regional Perinatal Intensive Care Centers, our Safety Net program, and then several subspecialty programs throughout the state with the various universities for geographical and condition-based illnesses or conditions like craniofacial deformities. The CMS plan is a managed health insurance plan providing health care coverage to children with special health care needs through the Medicaid and Florida Kid Care Program. It's in statute. There are about 88,000 children currently enrolled. That's a dramatic increase from 2 years ago when this information was presented before. And the CMS plan, again, serves children and youth under 21 years of age eligible for Medicaid under Title 19, 19 years of age or under Florida Kid Care, our CHIP program through Title 21, and again, children and youth with special health care needs needing extensive medical care. It's a family-centered comprehensive system of coordinated care, and the basis of the program, what really makes it a solid program, is the care coordination. And we think we've come a real long way in just a short amount of time with our care managers through WellCare. And we hope that if you've been experiencing it, that you've had good experiences, because our information indicates that WellCare is doing quite well, and we're quite pleased with the level of care coordination, the level of responsiveness, and overall quality of life for children with special health care needs. So,
I just have a question about, so there are no direct services through CMS anymore? It is all provided through the WellCare insurance?
WellCare has a network of providers that provide care. Yes, this is a managed care plan.
And so a child that goes into early steps and needs services and doesn't have WellCare, how do they receive?
They can still, through our eligibility criteria, can still get into the Early Steps program. They don't have to be members of the CMS managed care plan.
But if they become members of the CMS managed care, then they would receive services through?
We have a strong relationship with the managed care plan. Yeah, yeah.
I've been out of the loop.
Yeah. It's completely different now. Yes.
At 18 months and is receiving it through their own insurance.
Early steps through their own private, early intervention services or speech through their own insurance, not as part of our Early Steps program.
If they go into CMS, they might not be able to go to the same speech pathologist. Is that the case? Or is that happening if they switched over?
We have had part of our dilemma is we don't know all the children that are perhaps receiving services who aren't part of our Early Steps program. It's a big problem, especially for our hearing. So we think that our low numbers for 6 months hearing loss into Early Steps probably reflect the fact that some of these kids are in fact receiving high quality services, just not as part of our Early Steps program.
I can share with you an experience. I have, my daughter does early intervention services as a pathologist. My other daughter is OT. Anyways, but she had a baby recently, and he was delayed with his speech, and she made the decision not to go through Early Steps, and I asked her why. I asked her, well, it's just simpler. It's just a lot easier.
Okay, we aim to.
And that's a question that I'm asking. What's happening?
Well, I'd like to know. Clearly, at a minimum, we want to know where they are, and we don't know where everybody is.
Because they're receiving speech
Right.
privately through their own insurance.
We need better reporting. We need help from the audiologist in terms of hearing to report if they're providing services, but we don't know about it, because that's really, more than just numbers. We really do think that our numbers are more than 40, 50% of children who are receiving Early Steps.
Can I ask just a general Early Steps question?
Of course.
So I'm an independent, I do advocacy and educational consulting, and I'm in the Jacksonville area. And I used to be a classroom
Mhm.
services. Well, now in Jacksonville, almost every client that I have comes to me saying they're only offering me an ITDS.
Yeah.
I can't get anything else. I can't get therapies. They tell me I'm only allowed to have one, and if my child, I see your face, and I feel your face. They're saying, you know, they tell me that I qualify for speech, OT, and PT, but I have to pick the one provider that I want, and then everybody else will be a consult only. And I'm not talking about a kid with just a, you know, they're a little bit delayed. Most of my kids either have Down syndrome, cerebral palsy, so it's a lifelong. They're not going to get better in 3 months of therapy. And so they're not going to be as ready for preschool when they get to preschool, which then by the time they get to kindergarten, they're not as ready, so I have a harder time fighting to get them into an inclusive environment. But what I'm told when I call and talk to people at the Early Steps offices in my county is that's our model. We don't want the children having too much therapy. It takes away from their time. It's a family model. It's a coaching model.
And that it is, but
But is it across the state that they can only have one provider?
That was one of my daughter's concerns with having, with going to Early Steps, is she says they might just give him an ITDS, which is fine, but his need was definitely speech.
And what I'm hearing from parents is,
And so that's why she.
because when I talk to the people, it sounds really good. I like the philosophy. I do like the fact of, you know, no, the parent can't just go out of the room and you know, you need to be coaching parents,
Sure.
and teaching parents, but what parents are saying is, this person's coming to my house and they're just kind of like, get out some toys, what do you want me to help you with?
Okay, well,
I think in the crossover, it's not, something isn't working. And because of the pandemic, it's been hard for me. I haven't gone in since that model changed to really observe and see what it looks like
right. And where are you?
in Duval County,
In Duval.
Jacksonville. So I'm not trying to throw anybody under the bus. I'm just trying to understand what statewide does it look like, and what should parents be expecting, and you know.
And we've heard this, if I may.
Please,
Dr. Karsh,
please.
we've heard this from families, I think, in various different local Early Steps offices, and it's a shame, but it should be individualized. So
And that's
if
my thing. I'm
a
like,
child,
how
if family has
be like
specific
coming to an
needs,
IEP? Oh no, we don't do that.
right, it should be individualized. And with families, I would encourage them to look at their procedural safeguards, to know their rights, and understand what it is that they can and cannot ask for. If the child has specific needs and the family has specific needs, if it is a family-centered program, I would encourage them to ask for it.
In our IFSPs, I mean, they need to be individualized. Sorry.
Sometimes we have these families too that are younger, that have young themselves, moms that are 18, 19, 17 maybe, and they don't know to ask, so they kind of got, well, I'll just take what I get, you know, because it's more better than anything, but we talk about the individualized, you know, IFSP, but, you know, if they don't know to ask for it, then they're going to be slipping through the cracks too, and maybe not getting what
And
they
that's what I know is when I was a classroom teacher, I would always ask, if I had a 3-year-old coming in, were they in Early Steps, bring me a copy of their last IFSP and let me look at it. And they were so meaty. There was like so much good stuff in them. They looked real similar to what an IEP looks like. And then I have clients now as an advocate, and I say, well, when they tell me that, I'm like, you know, you have to kind of take with a grain of salt what a parent tells you because it's their perception. I'm like, well, let me see your IFSP. Maybe you're just not reading. And then I look at it, I'm like, well, it kind of is what you're saying it is. You're getting an ITDS and that's it. And it's once a month consult for everything else. And I'm like, well, do they come actually see your child? No, it's by phone or it's by Skype. It's
Marisol, can we,
frustrating.
can we take that and just take it back and discuss with Jessica?
Can I get my question?
Yeah,
Please,
yeah,
I'll give you my card as well.
yeah, thank you.
Excuse me, can I just chime in for a second?
Please.
The parent perspective is huge, I'm one of them, but it's also building provider capacity and having each Early Steps really make those connections with the providers out in the community as to why they should be part of the Early Steps system. Right now, we are looking at mostly ITDSs instead of speech, OT, PT, because I'm going to go back to billing, really, and just provider reimbursement
I appreciate that. Thank you, thank you, thank you. We have,
In some cases, an TDS is very much appropriate, but in some cases, who is low days or more medically complex, we may need someone who's more of an expert in that specific area of development.
and just take a couple notes here.
That's what I was at. Like, to me, if you have a child who, part of my area in my county is very urban. We have a lot of kids in poverty. I think we have like, you probably know, I think we have one of the highest like infant mortality rates.
Mhm.
Will County is, it's, you know, it's a little bit scary, some of our statistics. So having an ITDS as a family, I mean, really they become a family support person. It's not just working with the child, but it's really going, it really is important that you turn the TV off and get this book out. And here's what you can do with the book, even with a 6-month-old. Look what they can do if you just, no one ever did that for them, so I think they just don't know. Then I think it's important, but like you said, when they're medically complex, when they have these genetic chromosomal disorders that, you know, there's a difference between a child that's grown up in poverty and they test developmentally delayed because they've had zero exposure and experience to anything,
Right.
and somebody who's born with something that it's not going to go away. It's going to be there forever, and they need those really, that early intervention. We know if we don't get it, then in kindergarten they're not going to be taken into gen ed because they're just not ready.
Right.
I would like to contribute something on this discussion. Our program is really going through a transition, as you described, in moving from a more medical-oriented model to a more coaching, family-centered model. I have a child with special needs, tracheostomy, G-tube, and everything, and he's 17. And I use many of the strategies to this day. I found absolutely beneficial the coaching model for my personal experience, for his learning abilities. I know, I heard this, I think it was Dr. Weather, I don't want to cite someone if it's not sure, but I think she said interventions really happen in between sessions. So what I learned with my teachers is what I implement during the week, and then when I meet again with them, I say, this is what I tried, look, and sometimes I take videos, I show them, and it's a collaboration that really changed my practice, my style with him. When he was young, I remember driving 60 miles to free therapy so we can Gainesville from Dunellen, and it was so stressful. He was not learning anything, and back there, I'm talking 2007 or something, I asked to switch to an ITDS coming to my home in a very rural area. And it was the first time my son actually did something. Remember the first time he actually broke one hand over the other one. She used what I had at home, and she modeled it for me, and it empowered me so much. And I didn't speak English fluently back then. I was poor. The lights were going off every other month. But she saw potential, and she helped me to build capacity. And I am a strong defender of the model because I know when it's properly implemented is good. And I know we are, as a program, moving in that direction. Just bear with us and bring all that feedback back to us, because it's important to know the holes as we implement this big change in how we perceive things, how we can correct it. And that doesn't exclude the BTOT that we may need. Like Marisol said, is individualized, and we have to listen. Sometimes we switch. I had a speech pathologist helping us because he had some swallowing issues, and my ITDS was like, I don't feel comfortable with that. Let's consult. We were moving several months with that person who helped us tremendously because he had cleft palate, and to feed him was an ordeal. And I was wanting to feed my baby and build the relationship with my child. So it's very powerful, but I can see how she was mentioning the training across all our providers.
Mhm.
I think our program is an important step. That when we look at other states, in other states of practices, we are seeing that movement as well. And it really transforms not only the experience for the child, but for the family.
Thank you, Doris.
And to add to the individualized piece, a child may need certain services at certain parts of their development, and then may require that to change, or additional situations, maybe a family would want to come back on services, or, you know, my point is, it's very individualized, and, you know, to assign one ITDS to everyone is not the model. Even though we do use a primary provider approach, the model is sort of individualized.
And flexible. I always tell my parents, we write either on computers or paper, not on rocks, because we want to be changing this all the time based on your needs.
Sure.
I
Nice.
have my chisel.
Right. Well, thanks for the question, and I think we can get back with you, and yeah, excellent. Thank you, thank you, thank you. You've all heard of Title V. This is our maternal child block grant that we split at the Florida Department of Health between maternal child health and children's medical services for children and youth with special health care needs. Our priorities right now are developing and continuing to develop a system of patient-centered medical homes for children and youth with special health care needs. Our transition program, so ensuring that children have adequate transition to adult care, really starting around 12 years of age, and a successful transition to adult care, including, you know, bringing in adult providers into the program so that we have a successful transition. And I've seen in my own practice this transition not occurring as it should, and literally hitting your 18th birthday and next visit in 3 months is going to be not with us, and here's a list of providers that you might choose from, and that's not ideal. So we're working, we have some good models. Jack's Hats in Duval is a good one. And then our behavioral health, really expanding our statewide network of behavioral health hubs. We're actively trying to expand into Central Florida and the Panhandle. Those are our two priorities as part of a grant that we're applying to this year to expand our statewide mental health hubs to those key areas, and really providing capacity for primary care providers to handle some basic behavioral health treatment, assessment and treatment. No reason why, you know, a well-trained pediatrician, family physician can't do some of this, and that will clear up capacity for children who really do need to see a psychiatrist. There's just not enough, there aren't enough psychiatrists around. So really building that capacity for primary care physicians is one of our goals. Our specialty contracts, again, around craniofacial, chronic kidney, asthma, chronic asthma, and so on. Our multidisciplinary assessment team, clinical eligibility, medical foster care, I'll just talk about that. We have a pretty robust medical foster care program. Our medical foster care providers, parents, are aging out, and we have a bit of a crisis that we see coming, and so we're actively this year engaging in a recruitment program. We think that our 22 regulation boards, our regulatory boards, the MQA that I talked about, is a perfect area to focus and get some physicians, nurses, pharmacists, therapists. We think they'd make excellent medical foster care parents. So we're really going to focus within our, you know, licensed professionals in a recruitment effort for medical foster care. Again, Title V, children and youth with special care needs. There are 4.1 million children or so in Florida. 800,000. Okay, this circle here are children and youth with special health care needs. And then of those, a much smaller number, but really critical number, children with medical complexity requiring intensive, ongoing medical care. The Title V is out of the Social Security Act, and it's part of the Maternal Child Services Block Grant. And again, those are our priorities: transforming pediatric practices into patient-centered medical homes, like we talked about, building the capacity of primary care providers to treat common behavioral conditions, addressing the regional needs in the state. We live in a big, diverse state, so what may be appropriate or useful in the Panhandle may not be as appropriate in Broward County, for instance. So our regional Title V teams, improving access and quality. These are the specialty programs for our chronic disease, geographically craniofacial, sickle cell disease, pulmonology, endocrinology, and so on. These are long-standing contracts that have existed in Florida, and then collaboratively partnering with the CMS plan. Again, the specialty contracts, we use the NICHQ that I mentioned before, Learning Action Network. Really, we're teaching these programs how to embark on quality improvement programs on their own with the assistance of NICHQ. So that ultimately, if you're a nephrologist as part of this network, you're working with other nephrologists around the state in a true collaborative effort, not Jackson competing with Miami Children's and that competition in the silos, but rather developing a statewide approach of quality improvement that will help inform us as policymakers. And we think that this is a really worthwhile effort. The medical foster care I talked about, more information there, and you'll hear about our medical foster care recruitment efforts this year. And that's all. Let me just see where we are. The Florida Department of Health is a vast organization. I'm still, getting to know the bureaus and sections, and really the cross-collaboration potential that exists within the Department of Health. So many, I don't think a lot of people understand that so many pediatric programs, just because we're called Children's Medical Services, we have a pretty distinctive portfolio. So we are not immunizations. Immunization falls, under disease control. I don't think a lot of people understand that. Injury prevention really is the one that traditionally has handled drowning prevention and safe sleep, but we have the CATER review. We have the data. And so I think there hasn't been this communication and lots of siloing that, at least in my first year here, we're actively trying to break down those silos, communicate, and really get the most out of the Department of Health for all of Floridians in our great state. So any questions, more questions? That was a good discussion, and I really hope we can get back to you. Yeah, thank you.
I have a question.
Please.
I'm sorry, I was at another place, so if you're repeating yourself, I'm apologizing ahead of time. I was trying to handle 2 rooms at once.
Yes.
So my daughter has extensive medical history, as a lot of people do, and it seems like every time there's something new that we need, we have to jump through so many hoops, so many bounds. Well, you got to prove this, and you got to prove that, and you got to this. Not to be funny or rude, but you already have her 14 years of medical history. I mean, 1 year, I had to turn it into the courts one time because I was fighting something, and they said, okay, give us what you have for this year. 1 year. That was her stack of medical records.
Right.
So me saying that, 1 year times 14 years. If doctors are saying, hey, this child needs this medicine, this child needs this type of bed,
Mm-hmm.
why, as parents, are we literally gold mining, shaking for gold pieces to try to put this together to make it a safer and healthier environment for our children for 6, 8, 9 months while Medicaid decides if we're in review and are they going to approve it?
You shouldn't have to. And
it
it's
seems like that, it's like that across the board, whether it's something small or big.
yes. So I've experienced that as a provider, as a pediatrician on that side. You shouldn't have to, is the answer to your question. May I ask, is she part of the CMS plan?
She's on CMS. She's also, she has a part of hospice care as well. She has a very rare disorder called the Cardi syndrome.
Mm-hmm.
Only
Sure.
200 kids in the world.
Yeah. Cardi, a French physician, and he has a relationship to South Florida and
Yes.
Miami Children's Hospital.
Yes.
Yeah.
Yes, down in Miami. Yeah. So we have that, and there's different stages of her life. Where, like as you said before, sometimes you don't need stuff, and then sometimes you do need things. And so we notice, like during growth spurts, our medicines need to be changed.
Yeah.
During growth spurts, we have with the Cardi syndrome comes scoliosis. So we have a double curve. You can't have a brace with that. And so that creates another problem with walking. So now all of
How old is she?
She just turned 13.
13. So you were involved with CMS before the transition.
Yes, which that literally made me cry. Because we have certain specialty meds, and one particular pharmacy almost killed my daughter. And like they would say, oh yeah, we're sending you your meds, and then they never sent them. And the next morning I call and go, where's the meds? I waited after work at my job for you to deliver them. Yeah, we canceled your order last night, sorry, but we'll get them back out. And then they did it again and did it again. It was disastrous. And I ended up getting a pharmacy that is able to handle all of our specialty stuff from the medical marijuana on. And they get everything, and no lie, it has been over a year, because it was back in August whenever they started doing all that. Every month I have to call CMS and authorize, because their specialty pharmacies, well, they decided to go this way, so they sent your script here. No, you don't move my script. My script stays here,
Yeah.
where it's safe.
So you're tier 1 or tier 2, you must be. How do you feel your care manager? I mean, do you have access to him or her? And
I do have, there are some days I feel like she goes above and beyond, and then there's other days, when you were talking about when you turned 21,
Mhm.
oh, we've had hour conversations about 21, and I'm like, I'm just praying she lives to 16. We'll get to 21, but right now, can we go back to the back brace? I need to figure out about the scoliosis, the double curve, and about surgery, and she still wants to talk about, well, this is what's gonna happen when she's 21.
Right.
And I'm like,
I understand.
so, and I know that she does do some advocating for us. However, I feel like sometimes, and I hate to be that way, but sometimes I feel like I get really short. Like, I need you to give a damn about my child the way I do.
Yeah.
And I know she's the middle person, and I feel bad because she gets the brunt of things.
Well, at that tier, and we're really working with our partner WellCare to make sure that these case coordinator, care manager ratios are appropriate. This is the most vital thing. This is the
I don't know if she has, too many children,
No.
or if it's just that if you give a group of children, it's like if you're in a regular daycare and you have babies that are 6 weeks to a year. If you have more 6-week-old babies, you need to have less kids in the class. And if they have 10 children in their caseload,
Yeah.
and these are extreme cases, then they need to have less caseload.
We do have a tiered system, and it goes from tier 1, which is 1 to 15, 1 care manager to 15 patients. That's our our highest acuity tier. And then we go to 1 to 30, then 1 to 90, and then 1 to 200 for, your well-controlled asthmatic, for instance. So we do have a tiered system. I think we have a pretty good system. We're quite pleased with our care managers. We have some work to do. I think that we have an ombudsman program, and I wonder if you've taken advantage of our ombudsman program. These are akin to the family resource specialists in early steps. These are the ones that really provide that concierge service, if you will, to help you and understand
I haven't had that.
the ombudsman program. So.
Most of the things, and I can only speak for like the parents in my Cardi group that's online.
Mhm.
Most of the things that we find out, it's not because it was offered by someone else. It was because parents said, hey, did you get this service? What? Where did that come from?
Yeah.
Well, they've had it for years, but unless you ask for it, nobody tells you about it. Really?
Well, why don't you, if you would, and you can reach out to me, you can reach out to your care manager. I'd be happy to put you in touch with the ombudsman program. Your care manager will know about the program, and then, I'll give you my contact information, my card, and you can reach out to me, and I can put you in touch with the right person that can help you. I think we're seeing an improvement. I really.
I mean, I definitely will say this. There are a lot of things that have really improved.
Mhm.
So, I mean, however, from my They haven't. I went to other places, they sent me a text message, told me come get my medicine. I showed up, I waited a half an hour, and they said, yeah, we don't know why they sent that to you, we don't even have it, it'll be here in 3 days.
Yeah. Oh,
And so, like,
I'll look into that too.
I'll tell you, Publix was amazing, and no matter which Publix I went to when we moved, they took the time. And like, I panic over her meds, because obviously she's on very, very heavy seizure meds. We have 7 different seizures. And so when I got there, I said, look, I'm going to entrust you. You are my 5th pharmacy. In 5 months, I'm trying not to go to prison. Please help me. Like, my other kids want me to stay home too. And I talked to them and I explained to them the importance of it, and they were like, we got you, we understand. And when I tell you they were the most compassionate, and when we had to move, I was nervous. I'm like, oh Lord, there was probably just one pharmacy. It wasn't. Like, we had used 3 different Publix pharmacies, and they were amazing. And then all of a sudden I got a phone call saying, Mrs. Hicks, we just wanted to prepare you that in 6 weeks, Medicaid is withdrawing their contract and we will no longer be taking your CMS insurance. And I went, great, thank you. And then when I got a hold of, to try to find out what I was supposed to do, I was told, well, pick whatever pharmacy you want to go to. And I'm like, yeah, these are the pharmacies that I left because I was having a nervous breakdown every time I went. Sorry, this is what your choice is. And then when I found the pharmacy that I'm at now, which is Central Pharmacy. Central Pharmacy in Manatee County, they deal with everything that is specialty meds. The one lady, she was able to get Epidiolex for me in less than 20 days. Filled out the paperwork, got it. She's one of the few pharmacies
Yeah.
that'll carry it. So they were able to step in and take that place. But for those people who don't have the access that I have to Central, Publix was amazing for her kids. They really was.
Let me take that back to the team, and then let me give you my information so we can get you in touch with the ombudsman. And again, we're interested in hearing about issues with care managers and unresponsiveness. We aim to make the program better. We think we are. We're getting good feedback from parents, providers, and we're doing lots of surveys. We've been in now with WellCare for just over 2 years. We think the program is going quite well, but recognizing that for those who were used to the way it was, it's completely different now. So.
I'd like to thank whoever did the visual. There's actually a visual online where parents can go, like if your child, like where to go and the different phone numbers as
Oh.
well. I think it's really been helpful for whoever came up with that.
Okay, well, I'll tell. We have our bi-weekly meetings with WellCare, so yeah, well, I'll bring that back.
Yeah, more visuals are great. Parents seem to like the little charts, like where to go next.
Yeah.
You know?
Yeah, thank you. Yeah, yeah. Well, thank you. Any other questions? Hi. Hi. If not, then thank you for coming. It's been a pleasure speaking with you. I hope you learned a little bit about the Florida Department of Health. Feel free to reach out to me. I can direct you to the appropriate person if I don't know the answer, if someone could better help you. Thank you, Marisol and team, for supporting us here. And again, I think your program is exactly the kind of service that will help improve these programs that are statewide, massive programs. We need to hear from parents who have gone through all the hassle and all the trouble and stress and anxiety in just trying to provide the basics for your loved one, your child. So we are responsive. I think that's the kind of program at that level that we need to hear more from, and that's what I'll be committed to doing, is listening, participating at that level, because otherwise I think you can get lost in the bigness of these programs, these federal programs, state programs. So thank you. Thank you for having me. Okay. Thank you. Thank you. Are you going to be able to go to the session? Yeah? Okay. Yeah, let me give you my card. If I know that I must have one. I'm hoping, please help me.
Like, we went through 3 or 4 care managers, and we finally got this one, and we've had her now